Hello Echo friends, Tony from Echo.Guru here. Today we're looking at imaging the aorta and how we can think about its position within the chest and trying to help us to get these images a bit clearer and to interrogate things a bit better. A bit steeper. So from a standard parasternal long axis view, we don't see a lot of the aorta. We see a bit of the aortic root. We can see in this instance all the way up to the right coronary artery where it's got quite a high takeoff in this patient. Let me zoom in a little bit to look at the aorta a bit clearer. So we're able to see and appreciate the sinotubular junction and the aortic root quite nicely. We can see that right coronary artery coming into view. If we roll through that, I can optimize for that a little bit. See the right coronary artery. Not seeing the left coronary artery too well through here. But we'll see that in short axis in a little bit. What we don't see much of is a whole stack of the ascending aorta. Certainly we could freeze this, we could take a measurement through there, but it's just not that crisp an image. So what I'm going to do is, to be able to see the aorta a little bit better, is just track along. I've got an intercostal space higher and a little bit more towards the sternum, and we can optimize that mid-aortic ascending aorta a lot clearer. This is super important if the question is aortic dissection. It's not enough to image like this and think that you've seen the aorta. You've really got to track along it and follow that aorta as you head up towards the aortic arch. Now, as we age, our aorta dilates, both in its minor axis as well as becoming longer. The aorta at the aortic valve is fixed, and that's because it's essentially tied in by the pulmonary veins, which don't allow the heart to move much at this point. And so if we do dilate the heart, this point still stays in the same spot. Now if we have a look on the chest wall from where I've got my transducer here, the aorta is going to start coming up across through here, and we can see the angle that it's going through on the chest wall. It then does a U-turn up at the aortic arch, which is the tail of this transducer, and is going to wrap around back down behind the heart and sits in this plane through here. Now, as we get older, as I said, the aortic valve is the face of the transducer and it's fixed in there. It's also fixed at the ligamentous arteriosum, which is where a PDA would be if we didn't have that cleared off. So it's fairly fixed through there. So if we increase the length of the aorta as it dilates, to fit in that same spot, it needs to change that angle, and you can see now the face of the transducer, instead of heading straight up the sternum, is now heading across the sternum much further towards the patient's right-hand side. Now that's going to be really important to us as we're imaging the aorta and knowing which way to track along. So if we go back to our parasternal long axis view, well, that was a nice demonstration. It got gel all over the cable, which is going to upset me, but we'll carry on. So from here, I'm just going to follow along the index marker as I go up that intercostal space higher and I get to the mid-ascending aorta. As I keep following that aorta up, I'm now at the aortic arch. I've got my transducer around the wrong way a little bit. You can see the aortic arch through there and starting to head down towards the descending aorta. Now you can see from the chest wall images, I'm really not going a long way, probably because it starts off so high, and then you're governed by what's up in the aorta can't go too high up through there because of the suprasternal notch, and it's got to stay below the clavicle, obviously. So as I track along through there, we can see the descending aorta. We also see the descending aorta from the parasternal long axis view if we increase our depth just a little bit. We see the descending aorta through here. As I rotate through towards a short axis view, I can open up that aorta and if that's my target, I can follow through the aorta there. Now I'm going to slide down the chest wall towards the abdomen, following along that aorta. Till we go below the diaphragm. Going below the diaphragm, it's sort of almost like a two-chamber view through here. And as I'm moving along, as I'm sliding, I'm sort of also rotating as well to keep that opened up. There's the IVC. Here's the abdominal aorta. You can see it's pulsatile. It's got much thicker walls than the IVC. It can be a bit tricky sometimes, especially in young people. It can easily confuse the IVC and the aorta. So it's always worthwhile making sure that you image the two to be able to differentiate that, yep, that's IVC, and that this is the abdominal aorta. Reversing that procedure, I'm just following up as I'm going up into costal spaces, following the descending aorta. Pulmonary vein. Now, I had a little bit of a blind spot for a second there. I can image between the two to be able to optimize that again, but we're just not quite seeing it. Okay, so what that means, this is a young patient with nice images. We can see to get over towards that ascending aorta, we're not too far from the sternum. We're very close to the sternum here. In older patients who've got large dilated aortas, you might be a lot further medially to be able to image that on that right-hand side. Now, we're going to do a right sternal edge view to have a different look at the aorta of that section. Even though I've seen this well from this view, if I do need to see the aorta, I'm always going to do the right sternal edge as well. So what we'll do is roll the patient the other way. We'll ask them to roll towards us. Now this is a reverse of the original picture. So we've got the patient up on their right-hand side now. I get their right elbow up nice and high, and I've got their left arm down by the side through there. So it's exactly the same as a left lateral decubitus position, just rolled the other way and flipped around. I've got my index marker in the same position that I'd have a parasternal long axis view. I've drifted across to the right-hand side of the sternum, and you can see I've gone an intercostal space higher than where I started from my parasternals. In this instance, we can see the left ventricle nicely in this position. That's not normal that we can see that. Normally that's obscured by the lungs and we don't get as nice a picture. But it's perfect in this case because it really shows nicely the direction that the heart's lying relative to the aorta, relative to the sternum, and that if I follow that line along the index marker, I'm going to end up at my ascending aorta. And so here we've got a nice right sternal edge view of the aorta. Now, it's not the crispest of pictures. I can improve this a little bit by asking the patient to roll towards me a little bit steeper, and often they do need to be a lot steeper on the bed, almost leaning too far forward, to then be able to open that up nicely. It's also often very much breathing dependent, and I find we need to breathe all the way out on these views to get the image properly. So take a big breath in. Never get a patient to breathe out without an in-breath first. Take a big breath in for me, breathe all the way out, really empty the lungs. And that comes into view nicely there. Just hold that there. We can see where my arrow is. We've got the right pulmonary artery in short axis, and above that on the screen we've got the ascending aorta at mid-ascending aortic level, and we can see that really nicely. Breathe away, and I'll get you to do that again. Breathe in for me, then breathe all the way out. Perfect, breathe away. And you can see how much of an impact breathing has on that image. So very happy with that. Just breathe normally there. And you can see that's going to be a perfect spot then for me to use my PEDOF probe. Again, I'm going to slide that into position, leave the transducer nice and handy for me, making sure I don't drop that on the floor somehow. And I've got the face of the transducer angled towards the aorta, back to where the standard parasternal long axis view would be. We activate the Doppler. Remember, the aorta is heading towards my transducer now, so the flow is above the baseline rather than below the baseline like it is with the apical views. And again, we've got a breathing dependent image. So I'm just going to drop my scale down. I don't need 4 meters per second. If I need to turn my gains up so high to be able to make a nice envelope, then I'm not in the right spot. So my background gains should be nice and low. And that's a nice ascending aortic signal from the right sternal edge in a normal patient. A lot of people say you only do this in aortic stenosis. Practice on normal people, because it's a lot of the time we're going to get our highest velocities from this view. So you want to make sure that you're comfortable doing it. You saw then that didn't add any extra time to my scan time. If I'm already looking at the aorta for whatever reason, then it took me less than a minute to get a PEDOF image there. So it's really not a long time. And I was chatting away to you then. It wasn't just put it on and get the picture. If you practice with it, it doesn't take long, it doesn't add much to the length of the study, and you get a lot of extra data. So we've covered a fair bit of territory there. Hopefully that's been helpful in looking at the aorta. I'm sure we could talk about the aorta for hours, just a short video today though, and hopefully there's been a couple of useful tips. Look forward to hearing your tips for imaging the aorta. Love to hear them. I love to learn new ways of doing things. So make sure you comment in the comments field below.